Everyone. Welcome to the workshop session 6A, looking at mental health through the lens of trauma responsiveness. We're going to be hearing from Dr. James Rodriguez. Before we begin, I'll introduce myself to some of you who might not know me. I'm Ellen Early, and I'm a family support specialist at AFFCNY, and I'm going to be the moderator today for the Zoom. Training certificates are available. I'm sure you've heard this all day too for this conference. And I'm going to put the link in the chat box for training certificates and also for our book table fundraiser and the conference workshop evaluation. If you have any questions during this workshop, feel free to put them in the chat, unless Dr. Rodriguez, if you would like them to unmute themselves and ask, you can indicate that as well. And with that, let's see. So Dr. James Rodriguez is a senior research scientist and director of trauma-informed services at the McSilver Institute for Poverty Policy and Research at the NYU Silver School of Social Work. He's a New York State licensed clinical social worker and psychologist with over 25 years experience in mental health services to children, youth, and families. After 9/11, he coordinated the Children and Adolescent Trauma Treatment and Services Consortium, a multi-site evaluation of trauma treatment for children and youth impacted by 9/11 and other traumatic events. Following this experience, Dr. Rodriguez returned to direct practice at New York Presbyterian Hospital for Children and Adolescent Psychiatry School-Based Mental Health Clinic. His experience includes direct practice and training and research in the area of trauma treatment and trauma-informed care, as well as children's mental health in general. Dr. Rodriguez has also been a collaborator on the development of the Parent Empowerment Training Program, the Touchstone Training for Family Peer Advocates in New York State. His current work at the Institute includes the development and dissemination of training materials to promote trauma-informed care in diverse service settings. In addition, Dr. Rodriguez has a private practice and is the adjunct faculty at the NYU Silver School of Social Work. And I have two little ones here, so I'm sorry about that interruption. With that,
No
I'll
worries.
turn it over to you.
Thank you. Thank you for the introduction. And I forgot what bio I sent over, so it was a bit of the longer one. But thanks for that introduction. And I'm so happy to be here. Pat, it's great to meet you. And it's great to do some work with the coalition. I think Pat mentioned, or Pat was touching base with me about doing some previous work with Renee Heddick, who does quite a bit of training on trauma-informed care and trauma with the coalition, I know, and it's been wonderful collaborating with her, and her perspective on trauma-informed care has been so helpful to me in my work as well. And I also bring her in because, you know, we were recently collaborating on a webinar that we were doing together, and she mentioned the conference, and she suggested that I submit a proposal to present. And I asked her, I said, well, what do you think would be helpful? And she basically said, well, really, whatever you want. And very respectfully, and I was very honored for her to sort of invite me to submit a proposal. But she also mentioned that, you know, we have a similar sort of mindset around trauma. And so she invited me to present on anything. And so what I thought I would present is in some ways kind of a story of trauma. And I kind of want to pull out and talk about trauma more generally. It's not a comprehensive story about trauma. In some ways, it's a story that I kind of pieced together based on my experience, but also my training and my own education and my experiences. And so that's what I thought I would do. And what I want to do today, in many ways, is kind of talk a little bit about the very controversial, or it's sometimes controversial, complex issue of trauma and how we understand it. And so with that, my agenda for today is to touch on kind of a history of trauma, and talk a little bit about the point. I know we often talk about ACEs. My guess is many folks in the audience have heard of ACEs. But of course, there's a long history of discussions about trauma. So I kind of wanted to do a little bit of that, but also to put into context why it's so critically important to move from trauma awareness to trauma responsiveness. But also, one of my concerns sometimes is that when we talk about trauma-informed care, sometimes trauma-informed care gets confused or conflated or mashed together with trauma-specific treatment. And I always feel it's important to really distinguish those things because trauma-informed care is somewhat distinct from trauma-specific treatment. And so I'm going to talk a little bit about that today. So I'm going to talk a little bit about the history of trauma. I'm going to talk about this sort of, the way I think about it, this umbrella of trauma awareness, trauma responsive, and trauma specific approaches. And I want to talk about resilience, healing, and recovery, and kind of end with a bit of a case example from my own, actually my own early experience, actually as an early social worker. And so, you know, where I want to, oh, I'm sorry, before I start though, I did want to do a quick survey of the audience. If you can just chat in, I just want to get an idea of who all is in the room by your role. So if you can share with me what your role, if you're a parent or a caregiver, a family support provider, obviously clinician, a doctor, a provider, a community provider. So just to get a sense, if you can chat in and let me know what folks are saying, I just want to get a feel for the room and who's in the room. Actually, oh, okay, I'm sorry. So I see here kinship caregiver, adoptive foster parent, a lot of folks in kinship foster care, social worker in private practice, adoptive parent, permanency specialist, home finder training, foster adoptive parent. Okay, great. So a lot of looks like a mix of providers and case managers and folks working in the field, but a lot of foster parents and caregivers. Okay, thank you for that. Let me go back to my presentation. So as I mentioned, this will be a little bit of a story of trauma, and just to start off, you know, again, much of this may be basic, but you know, when we think about trauma, I just like to just, you know, sort of set the field and talk about the 3 E's of trauma. This may be familiar to many folks, but the 3 E's of trauma are events, experiences, and effects. And events are, there's a wide range of events that can cause trauma. And it could be an event, a single event, or a series of events or a number of events, but it could also be circumstances that folks grow up in that can expose folks to high levels of stress. So there are events or an event or events. And I say event or events because that'll be an important distinction as we move forward. And then there's the actual experience. And what I think is critically important, I think that's the most important piece to all this, frankly. Of course, the events themselves, and we want to protect everyone from being exposed to traumatic and horrific events, but it's the individual experience of the event, the subjective experience of the event as overwhelming, threatening, beyond the person's control. They're seen as life-threatening, and they can also, they can oftentimes affect someone's worldview and the way they see the world. And I think that's the critical piece. That's one of the reasons why 2 people exposed to the same event can have diverse and very divergent experiences based on that, because it's the subjective experience of the event that's important, not so much the event, not always the event. And then there's the effect, obviously with longstanding effects on mental health, physical health, social, emotional development, spiritual well-being. So there's many effects that can be experienced. And then just again, this is my brief little history of trauma. And I apologize for the font here. If I don't know why that's happening. It's a little bit of a funky formatting problem, but there's a long and controversial history. And I, you know, as a counseling psychologist, you know, I was trained in many fields of psychology and therapy and counseling. And so I'm always reminded, and I always like to remind folks that trauma goes back to, you know, Freud, and Freud in his early work really focused on what he calls seduction theory, and seduction theory was his theory based on a lot of clinical work. Now, Freud is a controversial feature, a person, and in psychology and psychiatry. But I bring him up because in his early work, he worked a lot with women who had been sexually abused. And in that work, basically, to make it super simple, what he believed early on in his work was that that because of exposure to sexual violence, that was in many ways the cause of serious psychological problems and mental health problems. Now, I know now it almost seems you know, obvious, But at his time, that was his main theory, that it was this exposure to trauma that led to serious mental health problems. And again, a lot of controversial issues in that, issues around hysteria. Certainly women in the feminist movement have often had many concerns about Freud's work, especially as it focused on women. But that was the idea. If you were exposed to serious traumatic events, especially sexual trauma, it could lead to serious mental health problems in life. But that theory changed over time. And so for those of you who are kind of maybe have touched on it, eventually he moved away from that theory and actually developed a theory of psychosexual fantasy, right? The Oedipal complex, right? This idea that sometimes sexual fantasies are often at the core, and psychosexual development and the critical importance of sex and sexuality became his theories, and kind of took over, and he moved away from that notion of seduction theory. But I also say that because some people have argued, and again, he's a controversial figure, but some people have argued that in many ways he kind of changed the theory because he saw so much sexual trauma in the world, that, and it was in all walks of life, at all levels of the community, and his world, that he started to think, there's a suggestion that he started to think it can't be actual sexual trauma, right? There are aspects of this that must be made up. So again, a lot of controversial issues there, but in many ways, again, he moved away from the theory. In addition to Freud's work, and so many people may be aware of this, but a lot of the early work and in the DSM focused on trauma, war-related trauma, combat-related trauma. And in the DSM-1, it was gross stress reaction related to war and combat exposure. In the DSM-3R and DSM-4 and DSM-5, post-traumatic stress disorder became the main focus of trauma, actually the only focus of trauma early on in the DSM. So post-traumatic stress disorder, which again, many folks are aware of. But again, it all focused on shell shock, combat fatigue, the notion that exposure to extreme stressful events have this effect on members of the military. And early on, the work focused on those folks. But only in the last 40 or 30 or 40 years has the idea that PTSD could develop as a result of sexual violence, that some of the work by Edna Foa, who was working with women who experienced sexual violence, found that many of them experienced the same characteristics associated with post-traumatic stress disorder that is often associated with combat veterans and people in the military. And so that idea is not long-standing. It's actually very recent. And then, as many of you know, the idea that children can develop PTSD is only came out in the recent version of the DSM. And again, I apologize because I know there's, so the just to be clear, the DSM is the Diagnostic and Statistical Manual of Mental Health Disorders. And basically it has, it chronicles all of the characteristic signs, and it's the way we diagnose mental health disorders. And so this is how post-traumatic stress disorder has developed over time in the DSM. And sorry for the acronym, and to make sure that everyone is aware of that. So again, but only recently has the idea that children could develop PTSD was put into the most recent version of DSM-5 that came out just a couple of years ago. So when you think about those things, a lot of what we know, and of course you all in this community know very much the impact of trauma on children. And then what you can't see on the screen, and I apologize for the formatting problem, but the last bullet in there is ACEs. And again, many of you may be aware of ACEs, the Adverse Childhood Experiences Study. And I put ACEs in this history of trauma because ACEs and the ACEs study really ushered in this large scale understanding of the impact of trauma and the impact of adverse childhood experiences. And in many ways, there's still a lot of controversy, even in the field. For some folks, ACEs, some folks don't always equate ACEs with trauma, which I know might sound ridiculous, but oftentimes there can be some controversies around the notion of ACEs and trauma and how it fits in this bigger picture, but it does fit in this bigger picture. And so ACEs came along and kind of really opened up. The other thing that happened very recently around the same time of ACEs is, we all have to remember, is 9/11. And 9/11 was also a big game changer in the trauma world because, and I should say not in the trauma world, but in the larger world that helped people understand the impact of trauma. It really brought trauma to the fore and brought it into everyday language for folks out there. So ACEs and 9/11, I think, were two of the more recent events that helped people really put and give thought to and understand the impact of trauma on a larger scale. And so again, just quickly for those of you who may not know, but the Adverse Childhood Experiences Study done by the Centers for Disease Control, I'm going to do this quick because many folks know, and Kaiser Permanente, it included over, it was a 10-year study involving over 17,000 people, and it looked at the effects of adverse childhood experiences over the lifespan. It was the largest study ever done on this of its kind, and the short story isn't, again, just review for those folks who don't know it, but what they found was, and the interesting story about the ACEs study, just for folks, is that it actually started through the work of Vince Felitti in his obesity clinic. And again, for folks who may not know this part of the story, he was working with a woman in his obesity clinic. They were working on some new ways of addressing obesity, and it involved a complex set of interventions, but also a very simple set of interventions around diet and exercise and healthy lifestyles. And his first client, who sort of ushered in the ACEs, the idea of ACEs, was a woman who was overweight. She was over 400 pounds, and she came into his clinic. She participated in his clinic and in the intervention, and she lost almost 300 pounds over time, over the course of a year. And it was kind of seen as an amazing achievement for this clinic. And then over a very short period of time, she gained quite a bit back. And again, this is the short story, but Dr. Felitti interviewed her and talked to her. And the short version of the story is that what had happened is the woman had lost so much weight that she was in many ways kind of propositioned by a coworker, and not in a very kind way, but it set her off. And what came out of that was that the woman shared that she had been sexually abused as a child, and that proposition by a coworker is what triggered this emotional response to her and these difficulties that she faced. And in many ways, her kind of regression in terms of all the gains that she had made in terms of her health. And that was what got Dr. Felitti to begin to think about this idea of trauma and exposure to adversity in early childhood and health. And so that was the impetus for the ACEs study. And again, many of you probably, again, now know that then what Dr. Felitti did, along with Robert Anda at the Centers for Disease Control, was really identify a set of early childhood experiences, adverse childhood experiences. And many of you are aware of them, right? Exposure to abuse, like physical abuse, emotional abuse, sexual abuse, physical and emotional abuse, household mental illness, having a parent or a caregiver with mental illness, parental incarceration, parental substance abuse, domestic violence, and divorce. And of course, you know, they kind of looked at these, asked folks how many of these that they experienced, and then asked them a number of health questions. And what they found was this very clear relationship between the number of ACEs that somebody experienced and a whole host of mental health, behavioral health, health-related problems later on in life. And these are some of the outcomes, and this is just touching and in broad strokes, some of the kinds of outcomes that occur later on in life. It increases the risk, and it's important to note, it increases the risk. It doesn't mean that these will happen, but it increases the risk for later on sort of health related problems and risky health behaviors, smoking, drug use, missed work, and all these other things, severe obesity, diabetes, depression, suicide attempts, mental health, cancer, COPD. So all a grand host of long-term outcomes into adulthood. But ACE isn't the whole story. And so there's another piece of that story, a couple of other things to add. First off, subsequent studies with more diverse samples have been conducted with similar findings. So in Philadelphia, they considered I should note, of course, in the original study, it was done with folks who were in the Kaiser Permanente healthcare system. It was a largely white, middle-class sample, educated sample. And so in subsequent studies, and a study they did in Philadelphia with a more diverse urban sample, they found similar outcomes and this similar relationship between the number of ACEs and long-term outcomes. And in part of that, research has expanded the list of ACEs. So in the Philadelphia ACEs study, for example, they expanded the list to include things like exposure to community violence, exposure to racism, exposure to living in extreme poverty and food insecurity. So they expanded the number of ACEs, and I should also mention for this population, for this group and this audience, that it also included being placed in foster care or being institutionalized, those kinds of additional early childhood experiences. And so that list of ACEs has expanded. And it's also ushered in a greater understanding, and actually not even greater research, because I'm sure Dr. Perry talked this morning about his research agenda that has been longstanding. But I think what it's done, it's really highlighted the work of people like Bruce Perry. So when Bruce Perry was interviewed by Oprah Winfrey, that was kind of a watershed event, because again, people are basically understanding this relationship. Dr. Perry's been doing his work for a long time, but I think many of these things bring and highlight that work to a greater level. And so there's been a lot more research and understanding the neurobiological connection between adversity and health, and then also a lot more research on understanding how we can promote resilience and recovery and healing. And Dr. Perry's work also talks quite a bit about that as well. And then just a quick piece. There's two pieces. Again, I'm sure Dr. Perry talked a lot about this. This is my very simple model. But when I talk about this is the human stress response at work when someone is exposed to a stressful event. And this is an oversimplification, I'm sure, in comparison to Dr. Perry. But when someone's faced with a stressful or threatening event, the amygdala, the emotional center of the brain, in that limbic system that I'm sure he talked about, kind of is the limbic system's alarm system, and it sends an alarm to the hypothalamus to produce stress hormones, and to the pituitary gland to produce more stress hormones, adrenaline, cortisol. So the body is prepared for responding to the threat. And what we know is, in many ways, that this is hardwired. We need this response. We need to have this response. It's biologically hardwired through evolution. And it was placed in there, and it developed in many ways to deal with threats. So when there's a bear in the woods, you know what to do. As we know, the problem is that ongoing and daily exposure to stressful events and chronically stressful events can lead to a rewiring and a restructuring of the brain, as Dr. Perry, I'm sure, talked about, that can make it difficult for people to be able to distinguish real threats from not so real threats, right? And again, I don't have to tell this audience, especially those of you who are caregivers, to understand that for young people, especially who've been exposed to so much trauma, it makes it difficult. So you see this stress response happening, you see the stress response happening with things that might not seem threatening to you or other people, but due to that child, and with I'm sure, very difficult behavioral reactions. And then the other piece that I'm sure Dr. Perry talked about was this brain architecture, this understanding of the brain from the downstairs brain to the upstairs brain, from the brain stem to the limbic system to the neocortex. The downstairs brain is the older part of the brain. It is the part of the brain that in some ways it's automated, it's automatic, it controls our breathing, it controls our blood pressure, it controls all of those automatic aspects of our neurobiology and our response. And then our upstairs brain is that neocortex, where our thinking brain, where we control our body, where we problem solve, where empathy lives. So that in many ways, the work that has been getting done in trauma and ACEs has really brought light to this as well, this understanding of the brain structure and the relationship between to that. And again, this work is so critically important to the future of treatment for trauma, because of our better understanding of the relationship between those areas of the brain and the architecture of the brain that can help to lead to new ways of approaching therapy and help and supporting children who've been exposed to extreme trauma, adversity throughout their lives. And then the other thing, and so this is the other piece that I like to add, is that in many ways, this work has caused me to think a little bit about how we think about the various forms of trauma. And again, going back to my original point, one of my concerns is that, when we confuse and conflate trauma with PTSD, we miss so much. And so this is my attempt to talk about the different kinds of trauma that are out there so that we can clearly understand how pervasive it is, how many people are exposed to it, the different kinds of traumas that people can be exposed to. And this is the kind of thing that we need to continue to educate people about, that trauma is not just PTSD, of course. And I know this audience probably knows that better than anyone. But so this is the way I break it down: acute and situational trauma. This is a single event or fairly constrained in time event. And so this can include things like accidents, assaults, rape, exposure to war, natural disasters, mass disaster events. So when you think about acute or situational trauma, that's where I do think about PTSD. This is one form of trauma. And so in many ways, the effects can include related to that event, re-experiencing intrusive thoughts, avoidance, hypervigilance, anxiety, change in mood and thinking. And these are in fact the symptoms, the characteristic symptoms of PTSD, of post-traumatic stress disorder. There's an exposure, there's these intrusive thoughts, avoidance of reminders of things that remind them of the traumatic event, negative alterations in their cognitions, in their mood, like incomplete memories, self-blame, trauma-related emotions, diminished interest in activities, withdrawal and emotional numbing, and then alterations in arousal and reactivity, being irritable, destructive, reckless. And so this is what we typically think about. But then of course, and I should mention again, going back to what I was saying earlier, that the other thing that's happened in the DSM-5 is that one of the things, and I won't go too deeply into this, but one of the things that they did in the DSM-5 is they created a separate category of trauma and stress-related disorders. It used to be that trauma and stress-related disorders were covered in a section on anxiety disorders, like social anxiety and generalized anxiety. And what the DSM-5 did was say, the origins of trauma and stress-related disorders are quite different than anxiety disorders. And as a clinician, I've treated anxiety disorders, I've treated PTSD as well. And it is very different. Someone with an anxiety disorder who has anxiety related to, and all the other anxiety disorders, may not be exposed to trauma. They have anxiety disorders because, for a variety of reasons that I won't go into, but they are very different from trauma and stress-related disorders. And I think because of the growing evidence that trauma and stress-related disorders are, and this is going to sound extremely obvious to this group, right, are obviously related to exposure to stressful life events, the origins of it, the causes of the disorder are very different than anxiety disorders. So it got its own chapter in many ways in the DSM-5, and it includes post-traumatic stress disorder, reactive attachment disorder, disinhibited social engagement disorder, acute stress disorder, and adjustment disorders. And so I wanted to do that kind of sidestep to talk about that's what's in the DSM. What's not in the DSM, and these are not diagnoses, is chronic stress and the exposure of chronic stress to the kinds of difficulties we see related to that. So when I talk about chronic stress, again, you can think about ACEs to some degree, that exposure to stressful life events. It might not be a single event. It might be daily exposure to stressful events, chronic exposure to stressful events that are not constrained in time, like those acute or situational events. And so some characteristic events like this is things like chronic poverty, and again, community violence, problematic substance abuse in the home, mental illness, neglect, demeaning or abusive caregiving. All of these things are daily stressful, daily stressors and chronic stressors that can lead to things like difficulty regulating emotions. I also want to be clear, these categories can of course overlap, but it also helps to understand there are different groups of folks defined by the kinds of trauma and adversity that they face. And then the effects include difficulty regulating their emotions, irritability, fatigue, headaches, sleep problems, on and on, all those lists of ACEs outcomes that you see. And then there's complex trauma. And this refers to the kind of exposure to multiple traumatic events. What's distinctive about complex trauma is that usually the distinction from other forms of trauma is in the absence of nurturing caregiving. And then there's the impact of that trauma. And so that's the way we often think about complex trauma, also toxic stress, that in many ways, acute or situational trauma or even chronic stress can be in some ways mitigated and reduced, or the effects can be reduced if there's nurturing caregiving. Adaptation and response and adjustment is more possible when you have nurturing caregiving. In the absence of nurturing caregiving and exposure to those traumatic events is what brings you to complex trauma. So these are severe traumas that someone may be exposed to chronically. And also what's critically important about complex trauma, it's usually interpersonal trauma, and more specifically, familial interpersonal trauma. So again, these things being at the hands of family members. And then again, this can lead to very serious behavioral health problems, more serious behavioral health problems, difficulties with functioning, long-term health problems, and developmental challenges. And then developmental trauma, which is very similar, but I like to distinguish it as well, because one of the things one of the ways people think about this is developmental trauma is oftentimes very early in childhood. So it can include things like in utero exposure to trauma, like drug use and things like that, and early early exposure to traumatic events. So this is, again, multiple exposures to traumas and multiple forms of trauma. It could include things like abandonment, physical assault, sexual assaults, threats to bodily integrity, coercive parenting practices, emotional abuse, witnessing violence and death, all of these things. But again, it can lead to these serious problems in development. These can lead to developmental delays, functional impairments, and of course, many of the other things that I've listed earlier: dysregulation problems, altered views of the world, oftentimes seeing the world as distrustful and unsafe, where that is almost hardwired in. And when I say hardwired in, again, I go back to nothing is truly hardwired permanently. Again, as I hope Dr. Perry's work has shown, and if for those of you who attended his work, is that we're finding so much more that you can heal and recover from even these these more severe forms of trauma. But I also want to make sure that, and this is the other reason why I think this way of thinking about it is also critically important. There's also various forms of multi-generational trauma. Historical trauma, it's one form of multi-generational trauma, and it's a form of multi-generational trauma that's based on specific cultural, racial, and ethnic groups related to major events of oppressive acts of human design. So here we think of things like slavery, the Holocaust, Native American genocide. And these do have an effect, can have an effect on folks' self-esteem, internalized racism and oppression, behavioral health problems. And we are seeing more and more, and I'm going to talk about it in a second, even in this day and age, the impact on of racism and discrimination in the here and now as well. And then intergenerational trauma, which I consider, of course, different from, it certainly can overlap with this notion of historical trauma, but intergenerational trauma is that transmission of trauma from parent to child, oftentimes through caregiving practices. When I think about intergenerational trauma, I think about that parent who was exposed themselves to trauma, that parent who themselves were also exposed to adverse childhood experiences, who find themselves being parents. And then oftentimes through a complex process of psychological and physiological mechanisms within that family, transmit their trauma and have children who then are more susceptible to chronic stress. Could be the result of intergenerational, could be the result of chronic neglect, physical abuse, poor attachment, inconsistent caretaking, but also involves things like epigenetics and systemic disparities. Epigenetics, again, too much to get into, but this transmission and this way in which genes are turned on and off. And so, and the effects can include anxiety, poor impulse control, and then and a number of others that overlap with some of those other categories. And then we have the trauma of racism and discrimination. And again, more and more, we're finding that in many ways, racism and discrimination is a critical piece of this, and it affects people in many ways, in similar ways to many of the other forms of trauma that I've already described. But it includes things like physical harm, exclusionary practice, oppressive practices, practices that keep certain groups from opportunity and blocking their paths to economic opportunity and participation in society. And so, but we do know that, again, those exposures are also critically important and have the same kind of physiological, neurological effects that I've described with other forms of trauma. And so in many ways, the reason why I bring all of this up is because as we think about the needs and exposure of trauma and what it is, right, there are all these things that can be mental health responses to a history of trauma and adversity in childhood. And the reason why I bring this up, though, is because oftentimes this is why our children are often misdiagnosed, right? Because there's that long history, and unless you're very clear about understanding that long history of trauma, what they were exposed to and when, and again, speaking to this audience and the parents, I realize oftentimes that can be a bit of a black box, and you may not know. But oftentimes, what I like to say about trauma-informed care and what I think is really important about trauma-informed care is that we understand we always respond as if. And in your case, and in this audience, I do know that folks here oftentimes understand that very acting as if, responding as if there's an understanding that someone was exposed to trauma. And what does that mean? If we act as if someone was exposed, well, we know that that traumatized children, and when you take all those labels out, when you take all those labels away, all those diagnoses out, at the end of the day, you have a child, and in many cases, an adolescent, and in many cases, an adult who's suffering, and as a result of exposure to trauma. It is about human suffering and related to histories of trauma and adversity, and that evokes fear, changes in worldviews, and changes in views about themselves. And so this is the way I think about trauma-informed care. There's trauma-informed care awareness, that is raising awareness and an understanding of trauma and what it means. I think more and more we need to be educating folks, and not just clinicians like me, although that's a big piece of it as well, because many clinicians need this in social work schools and psychology schools, need to understand more and more these relationships and the work of people like Dr. Perry and like Dr. Hughes and others. But that awareness, and then that moving into trauma responsive care, which is collective action. The way I see trauma responsive care is that everyone has a role in promoting healing and recovery. It's not just those with letters after their name. It is everyone has a responsibility, and a role for helping to promote resilience, healing, and recovery. And then there's trauma-specific care, which we know about, and I'll talk about in a minute. And then these are the core values of a trauma-responsive organization. And this is what I mean. And I often like to give this example. I am trained to do trauma treatment, not all kinds of trauma treatment. Dr. Perry's work, full transparency, I want to learn more about his work and be able to do his work, but I've done more traditional trauma treatment, especially of PTSD. But I like to say that even if I, as a clinician, do the best work, if folks aren't getting to me because my agency has practices that push people away in some ways, that are not inviting, that are not respectful, then I don't see them, right? It has to be part of a system that that also respects. And I could do the best work with a child on trauma, but if they're at a school that doesn't treat them well or doesn't know how to respond to them, right? I could do all the work, but it's going to be impacted negatively by their experiences at schools. And then of course I could do the best work with the child, but if I'm not collaborating with the family, again, it's not going to be as powerful and as effective, right? So it's about creating systems that focus on safety, that focus on trust and transparency. And again, I won't go into under details on all of these things, but it includes things like empowerment, voice, and choice, not only for children, but for adults, for caregivers, giving them understanding and information around how to approach treatment and how to get the best help that they can for their kids and themselves. In the case of adults, it's about collaboration, working together. And I know some of these things sound a bit pie in the sky, but they are critically important when we think about the needs of kids who've been so negatively impacted by trauma and adversity. It also means peer support, learning, and also having work with people with lived experience. As I said earlier, my collaborations with Renee are invaluable to me because of her lived experience in this work. It is collaborating with people with lived experience is so important. And then the importance of cultural, historical, and gender issues that certain groups oftentimes, because of marginalization of certain groups, people of color, women, members of the LGBTQ community, and others, oftentimes because of their participation in their groups, they're often exposed to higher levels of chronic stress, and understanding their needs becomes critically important as well. And then as we think about trauma-specific treatment, just a couple of things. So again, for many of you who talked about or who heard Dr. Perry's walk, right? His neurosequential model of therapeutics, right? He talks about things like music and movement, yoga, therapeutic massage, Reiki, EMDR, drumming circles, equine and canine, right? Working with animals and animal interactions, art therapy, drama therapy, right? All this list of things that really help to restructure the brain becomes so critically important. Problem is his approach is so extensive, and oftentimes, who pays for these? How do you get folks into these? How do you get supports to get kids into these activities? And then also, who's trained to do that neurosequential modeling? And please don't take that as a criticism of Dr. Perry's work. And I'm going to talk a little bit about this in a minute. But it's that larger social context in which we advocate for greater services that becomes critically important. And then I want to mention a little bit on, as I mentioned, the other thing that his work talks about is that this is the kind of traditional work that comes out of the DSM. The DSM and many cognitive behavioral therapies for trauma that focus on mainly on treating PTSD. What he talks about is all of that neurosequential work needs to happen. This work cannot happen with a child who has been exposed to trauma and has serious developmental delays or serious problems with cognition or serious problems regulating their emotion, right? But this is what we consider effective trauma treatment for trauma, but it only focuses on PTSD, right? And this is just a quick idea of what trauma treatment might look like from a cognitive behavioral approach, right? These are the kind of the phases of treatment, and I won't go too much into this, but it really is about being able to process the trauma that the person experienced. Again, not always possible for every child who's been exposed to trauma, especially those who've been exposed to trauma so early in their life that they can't process it at all. I'm just talking about some of the limitations. And then I want to end with this. So this is all about resilience building. The dynamic, and so when I talk about resilience, I talk about the dynamic, it's a dynamic developmental process of adapting well despite trauma, exposure to trauma and severe adversity. What resilience is, it's common and universal. One of the things I like to say is we are wired to be resilient. Regardless of what we demonstrate through our behavior, we are wired to be resilient. We are wired to adapt, all right? It may not always look that way, but we are. It's common, it's universal. It's also teachable and learnable. It is promoted in relationships with others. It can vary by domains, and someone can show incredible resilience in school, but not at home, or at home, but at home, but not in school or in the community. It can vary by domain. It changes over time, depending on life experiences, and sometimes trauma and later adversity can also undermine resilience and adaptation. And then it's at multiple levels. Our family, our bodies are resilient. Families can be resilient. Communities can be resilient. Societies can be resilient. And oftentimes it takes that integration of resilience at all those levels. What it is not is an individual trait. We oftentimes think of resilience, and it's a pet peeve of mine, but sometimes people talk about resilience as if it's an individual trait. You either have it or you don't. It's not. It's not a shield either. It doesn't mean that you will always be able to handle everything that comes at you, regardless of what's thrown at you. And then it's not fixed and permanent. It is dependent on the environment. And this is the way I also like to think about it. So resilience actually occurs at this intersection between individual strengths that someone may have, the importance of relationships with significant others in a person's life, parents and caregivers, siblings, family, friends, teachers, providers, mentors, teachers, others in the community. And then, but also institutions and systems. As I mentioned earlier, trauma-informed care is about changing systems. It's about getting organizations and agencies to think differently about how they approach their work. It's getting schools to understand and teachers to understand trauma. It also happens in the workplace, in healthcare, in the justice system, in the environment, and in government. And so that when we think about the approaches to trauma and bringing good quality healthcare to every child, high quality healthcare, the kind of healthcare that includes things like Dr. Perry's work and promotes that and actually pays for that, right? These are the kinds of things that can promote resilience. And I say that because, again, we think about in those in-between spaces, the importance of attachment relationships, connections and collaboration between systems, including families and those in the community, and then culture and values, how much attention we bring to these issues and how our systems are set up to make sure that every child receives safety and care at home and school. And so these are some of the individual characteristics I mentioned in the model: temperament, personality traits, ego resilience, competence, intelligence, future orientation, self-efficacy. But I give this list because many things on this list are teachable and learnable, are promotable. Things like self-esteem and self-efficacy, future orientation. Some are not, right? Intelligence, and depending on, there are different kinds of intelligence. So I want to be careful about how I say that. But sometimes these things are not malleable or very malleable, and please feel free to push back on that. But I think many of these things on this list are, that we can teach these, that we can help folks with many of these things, including young children. And then significant others, as I mentioned earlier, with a focus on families and parenting and the support that's given to children. And then the quality of the systems, as I mentioned earlier. I'm going to stop there, but I did want to share a quick story, and then I'll take sort of questions and get folks' thoughts in the chat. As I prepare for this last piece, I think about a story. Early on in my work, I worked with a child, and I was fresh out of social work school. And I worked with this young man. He was 8 years old at the time, and he was placed in what was at the time a size 7 classroom in New York City. It's a special ed classroom for kids with serious behavioral problems. 8 kids, all of which have serious behavioral problems. And in those, and I was providing what was mandated services at the time. And this was a child who had probably an ACE score of around 5, and he was 8 years old. He was exposed to drugs in utero. His mother was actually in rehab for substance abuse. His father was incarcerated and had abandoned the family. He was in kinship care with his grandmother. And so, again, at the age of 8, had already experienced all this adversity in his life. He had serious behavior problems in the class, learning disabilities, developmental challenges, constantly getting into fights, very reactive. And I was working with him. And I remember at the time sharing his story and sharing his experiences in a kind of case conference with my colleagues. And one of my colleagues very disturbingly said, you know, this child reminds me of kind of walking down the street and seeing a pile of garbage. And I was just so taken by that. And I apologize for that image. But what he tried to say was that that it's like you see it and you have no idea what to do with it. And so I was fresh out of social work school, and I didn't know what to do with him. I didn't know how to help him. I didn't know how to treat him. But two things happened. One is in talking to him about fights, and he'd gotten into a lot of fights. What I found out was in talking to him was that he often got into fights when people talked about his mother. And I had developed a relationship with his grandmother. I should also note that on a couple of occasions with his grandmother, I smelled alcohol on her breath. So he had an incredible relationship with her. She was incredibly loving and caring for him. But there were times where I smelled alcohol on her breath in our interactions, which was yet another ACE, right? But also I found out, and I really just worked to develop a good relationship with her. We had developed a nice relationship. And when I found out this, he told me also that he got into these fights with kids when they talked about his mother because his grandmother told him to do that. And again, I've been trained in a lot of parenting practices and evidence-based parenting approaches. So I don't typically do this. And back then I hadn't been. So I simply had a discussion with him, and I say grandma, and I called her grandma. I said, grandma, you know, he says that he does that because you tell him to. And I just want to ask you if you can stop saying that to him. But again, it was based on a relationship that I had with her, and she did it, and she stopped, and she had a talk with him, and the fights diminished. They didn't stop completely, but they went down. And I just had no idea what I was doing. The other thing that I did with him was I didn't know what to do with him. I certainly wasn't trained in the evidence-based treatments that I'm trained in now. I'm not even sure they would have been helpful. But at the time, I would spend time with him. I would talk to him, but I would also play basketball with him. And when I think about Dr. Perry's work now in this neurosequential model, I realized I might have been doing some of his work early on. I was doing basketball with him. I was doing something I was doing it mainly because it was something he enjoyed. But now I realize that I might have been doing some of that work on coordination, on helping him build from the ground up, right? As Dr. Perry talks. And I didn't know that. The reason why I share that story is because oftentimes, especially for those of you who are parents and caregivers on their call, go with your gut. A lot of times you're not sure about what you're doing. And we have to have great discussions about what we can do to make systems work better for the children that we're raising, that we're living with, that we, in many cases, support and provide care to as professionals. But we also have to go with our gut, but also continue to push, to bring in facts, to bring in the science that we know, to make sure to improve quality systems. So I'm going to stop there and hopefully have some time for discussion and take some questions and get your thoughts. I hope this was helpful, but let me stop there and see if there's any questions out there that folks, I've stopped my screen and so, Renee's there. Hi, Renee.
Hey, Jim. So great to see you.
I see your question. Renee, unfortunately, I don't know. So Renee's question is, can you give parents guidance regarding how to obtain neurosequential services versus traditional talk therapy? In many ways, I'm glad you raised that. That's where I think we need to go. We need to make those kinds of services more available. Working with Dr. Perry and working with others, whoever else will listen and talk and help to, when I think about Dr. Perry's work, and I mentioned this to Renee in a discussion we had, I think of a man named Ivor Lovas. For those of you who have children with autism, Ivor Lovas did a lot of work as applied behavior analysis, as an applied behavior analyst. And basically in his work, he did work with kids with severe autism. And what he found through his work is that kids with severe autism need about 40 hours a week of serious applied behavior analysis, which kids with severe autism need serious applied behavior analysis in order to be able to see improvements in their behavior. Now, again, also a controversial figure, and many people have different opinions about applied behavior analysis. But my point is that he did the science and he showed that this can have truly helpful effects on children with autism. And there are many other approaches. But the reason why I bring up that point is this is at many parents and caregivers and folks who work in the autism community oftentimes push and have to advocate and push for those kinds of services when they're not available, but also to make them more available and to make sure that there are people out there trained to do it. So I say that, Renee, because I don't know where to go for those. And maybe that's part of my work as well, is to find out where you go for those. But my guess is we also have to increase the capacity and the number of people who are out there available to do that kind of work. Andrew Bell. Andrew Bell is here. I don't know if it's the Andrew Bell I know, but I hope so. I agree completely. There's so many bottom-up approaches I'd like to see part of our traditional. Yes. Andy Bell, is that you, my friend?
It is. Oh. Wonderful presentation as always, James. Thank you.
Thanks, Andy. Yeah, Andy, and Andy, you're a great advocate as well. And I think and we need to do more of that work as well. Kimberly has a raised hand. Kimberly, would you like to share?
I would. I'll try to be brief. I could share on many things, but so I have I guess I have self-diagnosed complex PTSD, and I adopted 2 children as infants from Guatemala, and I didn't do a great job. They're teenagers. I mean, I don't mean to be self-deprecating, but there are many things I wished I had known and had more support with. So I guess my question is sheer love and acceptance at this point, instead of reacting to the behaviors that I sometimes feel like we're self-seeking, like this adversity, and then me reacting to their behaviors. How powerful is that? I mean, I guess I'm looking for I feel like it's powerful, but that's all I can give. I can, get therapy for them, and they do both go to therapy. But I'm just wondering if my mindset changing can be incredibly healing for my kids, based on just sheer acceptance and love and care. And because I have worked a lot in the past few years, and things have changed in that way. And I want them to feel safe, and they're both really traumatized.
Yeah. Kimberly, that's a wonderful question. I want to sort of break it apart a little bit. I think the love and care is critically important, and absolutely that makes a difference. But I think in addition to that, what we're finding is again, as we're saying, there's all the science, right? So I think this is about, I think the science is there enough to know about the effects of trauma, but the science is there enough to know about what helps. And I think this is about collective will to bring those. But I say that, Kimberly, because yes, love, nurturing, caring, relationships. And what we do know about resilience, we do know about resilience is the one thing that just across so many studies shows can be the critical feature is the presence of a loving, nurturing relationship with a trusted adult. Again, much better if it's a parent or caregiver, but anyone out there. a mentor, a teacher, right? So that's what we know. So I say that because yes, but then I also think, right, there are all these treatments that are out there that we need to make more available. So that, along with love, along with evidence-based treatments and science and applying the science that we know and bringing those to the folks who need it most, is to me the path forward towards full health and recovery, and giving folks the greatest opportunity for recovery and healing from trauma. And so, so there was another part of your question, but I apologize because I realize we're at time. But there was another part of your question that made me. Oh, I'm sorry. The other thing I wanted to say, Kimberly, is this: I hear the blame and the self blame. And what I want to say to you, and normally I would process this with you as a therapist. There's not time, but what I would say is that's the other piece. You all as caregivers are doing a difficult job, and you're doing it beautifully. What we need to do, and actually Renee and I just did a webinar on this very topic, on the importance of providers being able to work to develop strong, positive relationships with parents and caregivers out there. And one of the things that we talked about was how do you help and work through that blame and shame that parents can often live with when you're raising a child who has serious difficulties and has a long history. So that's the other thing that your comment makes me think about, is that that's part of it. And what we have to do as providers is to help you through that as well. And sort of disabuse you of that blame and shame, which I know is difficult oftentimes to do, but I think that's also part of the work, is supporting parents and caregivers like you. I just want to sort of defer to the coordinators. I know we're a little over time. I'm fine with staying, but I just wanted to check in and see if there were any other burning questions or.
We can go good 5, maybe 10 more minutes, and then we have to break out to the other room. So if there's more questions, I would say you probably have another good 1 or 2.
Yeah.
So this is
Okay.
Renee, Jim. So
Renee.
I've been looking at the chat for you. So there was 2 other additional questions that hopefully you can answer. One was, how do parents then work with the schools to help them become trauma responsive?
Well, and again, that's a great question, and this is what I mean about this notion of resilience. That and I saw another question about, and I think someone put it gently. They put, how do you teach resilience? And that's my point. It's that some part of it is teaching. When I say that, we have these evidence-based treatments to help people deal with trauma, I see that as resilience building. When I'm helping a child regulate their emotions or teach them regulation skills, when I'm teaching them how to restructure the way they think and think differently about things. All of those things, I believe, I'm teaching resilience. I'm teaching them the things that they need to do that are those individual strengths that build resilience. But to go back to the question that you raised. Oh, I'm sorry, Renee. I kind of diverted to that. But what was the question again? I'm sorry.
Schools.
So somebody asked.
Oh, right. Schools. And that's the reason why. So when I say that, right, I'm building individual resilience. But as I mentioned before, when I think about resilience, I see it as this other piece where it's about this collaboration. So parents, I think, need to be armed with their understanding of trauma, and which can be difficult. But that's also where providers come in. That's also where providers who should have, along with parents, that same understanding of trauma, that same understanding of the impact of trauma, what it might look like. And actually, to Kimberly's point earlier, we need to work with them as well as parents like Kimberly in terms of being able to help them reframe the behaviors they see from a trauma-based perspective, as opposed to traditional perspectives that say that child is just being willful, attention-seeking, they're just bad seeds, so on and so forth, right? And then all the exclusionary practices that we do for those kids. So we have to reframe it for everyone in the system, and that's part of the point. So to answer the question, though, I think it should not just fall on parents; it should fall on providers, and parents and providers working collaboratively with schools to help them reframe and understand children's behavior from a different perspective, and in many ways help them understand also how to respond to those kids differently based on our understanding of trauma. And I realize a lot of what I'm saying is aspirational. It's kind of pie in the sky. It's where we need to go. So I do want to be mindful of the fact that this is not everyone's experience here. And I realize what I'm talking about right now is much more sort of future oriented. It's not what's happening, but I also think it's what we can all do as a group to advocate for improvements in the system.
So Jim, I'm
and I
going to
guess
jump in.
Yeah.
I'm just going to jump in one last time before you have to go. There's been a number of questions about, trauma therapies like EMDR, trauma-informed CBT. So you can't answer those kind of questions in the next 3 minutes, but where would you direct parents so that they can learn about EMDR and CBT and all of those types of trauma responsive therapies?
Well, I would say, I hate to sort of go to the obvious, but nowadays, you can go to Google, you can go to, many of the medical sites. You can go to also, I should say that the American Psychiatric Association, APA, actually the Psychiatric Association, not the American Psychological Association, the American Psychiatric Association actually has a pretty good website where and it has a bunch of resources for family members, and so they're very much sort of catered to giving information to family members that help them understand some of these evidence-based approaches. But I do think Googling those. So probably my sort of contribution to this is being able to say, this is what you can look for. This is what you can look for. You can look for things like trauma-focused cognitive behavioral therapy. You can look for EMDR. So those things that people put in the chat box, and look them up. There's information about there, and oftentimes very simple information that describes the treatment and the approach. And actually, as you say this, Renee, I suppose at my shop and in the work that we do at the CTAC, we can also do some more work around defining those. But there are many. Oh, I'm sorry. I should say the other great resource for this, the National Child Traumatic Stress Network, and I'll put it in the chat. The National Child Traumatic Stress Network is a great resource. That is their job. Okay, folks, thank you very much. I'm going to stop there because I realize we're way over. Thank you, Renee, for inviting me, Shami, for our time together. Pat, pleasure to meet you, and thank you all for your time.
Thank you so much. You have a great night.